Hello, everybody. Welcome to our final session of the final day of the Youth SUD Learning Series. So our next presenter is Mitch Doig. He is from the University of Washington, and he's going to talk to us about ensuring youth know their rights.
This is where I tell you I'm a notorious low talker. So if you can't hear me even with this, please, it won't offend me to let me know. As you just heard, I'm from the University of Washington. I'm based in Oregon. I've lived in Oregon my entire life. And I come from this wonderful, cool program that I don't know if everybody knows about called the Northwest ATTC. I would like to just do a little bit of a spiel about them because one of my big kind of passion points before and since joining the team was that I think that you shouldn't have to pay for CEs if you don't have to. And a really cool thing is SAMHSA has this grant that operates on a 5-year cycle that we provide free and low-cost training and technical assistance to a 4-state region. I got some of the best training I've ever received in my life through the ATTC before I was hired by them, and now I'm really excited to actually be a part of them. So that's really what I come through. The University of Washington houses our program. There's a bunch of regional centers. Highly recommend checking out the website. There's on-demand stuff, but our in-person and our virtual trainings are excellent. And sometimes you get to see me do them, which means they're really good, right? Hopefully. So we're here to talk about youth rights. This is going to come with a little bit of a perspective, or most of a perspective as me as an SUD clinician. However, this doesn't really get less murky or more murky when we move away from substance use disorder treatment. There's one little caveat to that, and we'll talk about it, but really there's going to be this magic age number we're going to talk about, and this other magic age number we're going to talk about, and then this other one that gets a lot more scary for our youth. So we'll talk about all those things. Hopefully clear up any confusion, but really the idea here is that you'll walk away with just a cool framework for how to talk with youth about their rights, how to make sure we're clarifying this, and how to make sure we're doing this in an ongoing conversation, which I think if I had clicked ahead, all of these words should match the thing that I just said. And we're going to be using this thing called EPE. Does anybody in here know what motivational interviewing is or have some experience in it? Okay. It's a tool that we're stealing or borrowing or adapting from MI. It's really useful for delivering a bunch of information in a short amount of time or a bunch of information over a longer period of time. Great little skill. The other kind of big thing here, is it this guy? Yeah, I do. I was told that if a cat walks in, I can do this, so. You close the door, though. So this is kind of the biggest thing that I think a lot of people are here for, which is this conversation about informed consent. What I would love to do before I talk a lot at you is to let you talk a lot at each other about this, though, because it'll really inform what's happening in this room today. So what I would love you to do, either at your table with one partner, with 2 other partners, doesn't really matter to me, just talk about why you signed up for this session, and then also come up with 1 to 3 things that you think youth in your care, and that could be whatever your role is, should know about their rights. I'm not going to say what kind of rights or anything, but just take like 3 minutes to talk as a table, and then I want to ask a couple questions. Okay, so I realized the fun thing is I didn't tell you how we would be debriefing this. That's probably not a good way to lead a conversation about informed consent. What I would love to be able to do is for each of the tables to just share one kind of big thing that you heard, whether it was the reason somebody signed up for this training, or the right in particular that you thought the youth should be aware of. And I heard that you could be wonderful and hand a microphone to somebody who would be daring enough to talk into one if somebody would love to share those things. Just one thing per table.
Yes, I'll also say that we're using the mic so that way the recording can pick up your question too. So even if we are like a small group of people, it'll still be helpful.
I think we were in agreement here that youth are guaranteed the right to privacy. There are times where you have to break that confidentiality, but especially with SUD counseling, that's paramount to your client.
I think one of the biggest challenges to that right is the conflict with the laws about access to charts and saying when parents can and can't access that stuff, and making sure that kids know that like sometimes there's things in your chart that I have no control over who sees that.
The general takeaway I got is that we're trying to muck through like all of the different complications based on our individual spaces we work, and making sure, I think at the end of the day, that we're showing up as the best humans to support these really vulnerable humans, and how that gets communicated out.
One of the fun parts is whenever I talk about our kind of client rights or ethics that are very client facing, I think the room really quickly kind of coalesces, and we're all like, this is what I'm struggling with. And the worst part is this is, you've kind of already said everything that's in the presentation, so I can just leave and see you later. No. The question that I always like to think of that I feel lucky probably that this happened is, I think there's one big question that pops up in my mind that is actually kind of thematically similar to the thing that each of you all just talked about, which is when this question happens. When there's a moment where you ask a question, or there's a weird kind of silence in the room when you're talking with one of the youth that you're meeting with, and they say, this stays between us, right? You're not going to tell my mom. You're not going to tell the probation officer. You're not going to tell my teacher. All of those things start to kind of happen. And I think the really, really annoying part is then this happens. And we're like, I don't know. And this is actually really, really hard if we're talking about care with youth. I think an adult, truth be told, could handle this answer. I think that would be a fair thing for me to say in the moment with an adult, you know what, let me go check, I'll be right back. I think the second we do that with a teenager, we've lost kind of all trust and expectation that we'll be able to know things in the future. There's a lot of pressure working with teens in particular, and not because teens are harder. This is one of the stories I love to tell in case you're somebody that isn't currently working with youth and you want to. Way back when, I decided to go back to school. And in one of my classes, somebody at the start of the term had been asked, why are you getting into the field? And somebody said, I want to go help teenagers. I got into recovery as a teenager. I want to go do this. And our instructor said, ooh, you're going to change your mind after a year. And I remember the rage that I felt in that moment as somebody who wanted nothing more than to work with teenagers. And somebody reached out to me one day, and I've never met this person. I said, hey, do you want to come work with teenagers at this really cool outpatient program? I said, yeah, I want to go do that. First day on the job, I called in a panic because this question actually came up and I didn't know what to say. It's not something very clearly spelled out in a lot of literature. It's not really covered in any of our courses usually. I feel like a lot of times we just say here's adult confidentiality, and when you maybe end up working with teenagers, good luck. Well, you'll figure it out. So hopefully we can not do that. Hopefully. And I think the challenge, before I kind of remove this little confused fella, is there's a lot of things that govern this decision of how we answer this question. Some of the things you already brought up. So there's HIPAA, it's kind of this overarching thing. Most situations, there's going to be a HIPAA or kind of a FERPA law that's going to be around everything we talk about youth. It'll protect some things. It'll give us some guidance about what their charts look like, what our documents look like, but that doesn't really answer the question that kid asks. What the question they're asking is, in this moment, is what I'm about to tell you going to stay between us. And as you pointed out with those documents, I don't know. Then if you're working in SUD, there's this really, really fascinating law called 42 CFR Part 2. Show of hands really quick. How many of you are familiar with that? Sweet. Okay, it's one of my favorite little things. The way I like to describe this for those of you that don't know what this is it essentially prevents, or ideally would prevent your counselor, who you've told a bunch of illegal things, which is, I use drugs, that you're doing illegal things, and then they'll call the police, and then you are in more trouble for seeking help. And so this was a law that was instituted to not dissuade people from entering services, because what they're doing at the time was illegal. It was something that was founded during the kind of, I would say, early peak of the war on drugs, when we went really hardcore about busting down doors. And good move. And makes things a lot more complicated, because I always like to joke around my mental health kind of counterparts. They can share information a little bit more freely. You call me and I become iron box, you're not getting in. That can be really, really neat and really, really challenging, and I'm going to share a story later about where it gets challenging. Then there's this other layer where the state you live in might even have some additional laws. The really kind of confusing thing about confidentiality law sometimes is we think about kind of moving from a federal to a local level for law frameworks. You can be more strict. You can't usually say, like, do whatever you want. There are ways that this happens. We're kind of seeing this in Oregon right now with decriminalization. That's in kind of conflict with federal law, but we can do those things anyway. This doesn't exist in Oregon for confidentiality law. We kind of refer back to HIPAA, but HIPAA does this interesting thing where it refers back to the state. They kind of go back to one another, which is good for us in some ways, because this allows us to be really clear in our Oregon administrative rules rather than kind of have to defer to HIPAA all the time. So we have some language there. And then finally, local. You could theoretically have some local governing rules that really throw this all out the window. I'm not aware of any in Multnomah County, but who knows? It's possible. But like I said, it's deferred to a state regulation, which means we have really precise language that I can share with you today, which is really good. But before we get there, I think it's really, really important to highlight that our answers need to be provided confidently and accurately, otherwise we lose credibility. Somebody one time told me that youth have a differing sense of justice, and that's what really causes most of our kind of power struggles. I worked in a lockdown residential program for girls who were 12 to 17 years old. 9-month program usually for completion. For the first 6 months, doctor's appointments are usually the only reason people left that building. I can think of a couple more situations where you're removing more autonomy from a person than that, but only a couple. And I think it's a beautiful program. I think it's one of the coolest places in the country, honestly, for doing what they do. But we ended up in situations all the time where a kiddo would say, hey, Mitch, I would like to do X, Y, or Z. And I would say, hey, you can pick anything you want to do that's in this box, and X, Y, and Z is not in this box. I'm sorry. It's not a fun way to lead a conversation. So we have to actually have some strategies for how we're going to have that conversation, because our answer doesn't change, unfortunately. Sometimes the answer is the answer, but we want that to be heard correctly. Clients have a right to be suspicious. I'm going to share some not legal rights, but I think rights that are really important to think about here. They have a different sense of justice. They might know more than you think. Again, show on the hands for SUD providers in the room. Question, how knowledgeable on a scale of 1 to 10, you can just hold up your fingers. Actually, let's go 1 to 5. How knowledgeable are your youth about the effects of cannabis on their body? 5 being really, really accurate, and just a fist if they're not accurate at all. 2, yeah. Kind of differing, right? Now, if you ask them instead about how cannabis is made, manufactured, ways you can consume it, all of those things, usually pretty knowledgeable. Youth seek out the information they want. There's this really cool thing called YouTube where you can just find a tutorial on anything you want to do on the planet. I've become a pretty good graphic designer and video editor as a result of YouTube. They could look up a lot of stuff, but you know what there's not a lot of resources are? Is hey, my mom just told me I have to go to drug treatment and I need to know what my rights are. What'll happen is you'll find kind of message boards, you'll find a Reddit thread where somebody said this was BS and my counselor told me I could do X, Y, or Z and now I'm emancipated. You'll see things like that. And you'll get the frustrations of that youth coming in and said, I think the only way out of this is I have to get emancipated because my mom's not going to let me go to my party this Friday. That's kind of the short-term framework. And I know I'm joking a little bit, but I think that, remember, timescales are really cool when you're a youth because 1 month of a 16-year-old's life is very different proportion of a month in my life. A month is Saturday, basically, for me. So they also might have misconceptions, as you mentioned, by the 1 and maybe 0, maybe 2. They might need things repeated. I was 16 years old once, and I also thought I was the smartest person on the planet, and my parents were stupid. So sometimes I needed things kind of repeated to me. Repetition's good. Now, what I didn't love was repetition that was the same thing over and over and over trying to drill into me. So repetition, asterisk, different, though. And also, they live in a grayer area than a lot of our clients in other age groups. It's not like a 9-year-old kid. This is really kind of cut and dry a lot of times. 19-year-old person, very cut and dry a lot of times. 17 years old, there's this magic birthday coming up that's going to change the whole world for them. And that gets really complicated. So we're going to talk about all of those things today. So before we do that, though, because I had mentioned kind of so much about how this is really a communication issue, let's talk about how we communicate as humans. So the first thing that happens, my name is Mitch. I have this really cool idea. It's going to be great. You're all going to be very moved and empowered by these ideas I'm going to share with you today. That was maybe a lie. I don't know. I'm going to try to speak to all of you caring professionals about those ideas. Hopefully, your ear holes hear the exact same thing that my mouth hole said and that my brain produced. And then you had the exact same message. That means there's 4 places where communication can break down. I could think it maybe not super perfectly. I could say it not super perfectly. You could kind of hear it a different way. And then finally, you could interpret what you heard a different way. Lots of places for this to break down. Now, the other thing that can happen, and this is where it gets a little bit different for our youth, is the same process occurs, but then the kiddo leaves the office and tells kind of whatever they thought they heard. So then you have this 5th part of communication breakdown, and actually kind of a 6th, because then that other person will then hear and then also kind of interpret that through their own messaging. My favorite thing, I mentioned motivational interviewing earlier. I would consider myself pretty decent into the practice. And one day I got a very angry phone call from a mom saying, "Why did you tell my kid they can smoke weed all they want?" And I said, "Did I say that?" And I had to really sit there and think. And what I realized was there was a reflection. By the way, there's this thing called reflections in motivational interviewing. There's this reflection I offered where I said, so in a perfect world, you would be able to just kind of smoke all day, every day, and mom would leave you alone. That was the reflection that the kid had to be like, Mitch says I can smoke weed all day and every day. Mom's going to leave me alone. And what that opened up for me is we actually have to look at these conversations about confidentiality as kind of direct and third party. We don't really get a choice of just working with the teenager. And again, lots of you in this room working with teenagers. My assumption here is that you've kind of experienced a day where you put in a good 8 hours, maybe 10, maybe 12, who knows. And you thought to yourself, man, my life would be a lot easier if the parents weren't involved. Yeah. I've had a few of those days. A few days where I was like, man, if I could just adopted this kid, gave them some pizza pockets and Wi-Fi, gold, this will be great. I have ethics, so I didn't do that. But I still think I was right. So let me just go through this really quick. So the way we want to clarify things, I'm going to give you the tool first, then I'm going to kind of walk you through key points when this can be used. So the tool I mentioned is this thing called elicit, provide, elicit. In the new motivational interviewing, 4th edition, came out in August, they now actually call it ask, offer, ask. Same tool, I promise you. The idea is we want to first elicit what the client already knows. There's a lot of ways you might ask that. You might say, what do you already know about confidentiality and your privacy and what you can consent to? You might even say, what have your friends told you about it? What did other people tell you about it? What are you worried about? You can ask all these really cool questions. But then they have to tell you. And I think that one of the hard parts is youth will say, I don't know, nothing. They'll kind of give you the one-word answer. That's okay. Then we say, is it okay if I share some things with you? This is the really neat thing that we get to do with every single person involved in this youth's team. Let me share things with you. In this section, I want to really highlight this one line that says tailored to their needs. Consent and confidentiality needs to be heard very, very differently for your client and their parent. There was something that was brought up that I had heard kind of happening when I was walking around the room. Sorry, I was eavesdropping. Where the challenge here really lies with how protected this information truly is. I worked with the youth one day. I'm really glad I think sex ed something. Yeah, okay. I worked with the youth one day. I was at Park Rose High School. I used to do a lot of school-based services. And this girl comes into my office and says, Mitch, I'm freaking out. I'm pregnant. I don't know what to do. And I remember instantly thinking, holy crap, this person's only goal in life. They came from a grandmother who had a kid when she was 14. Came from a mom who had a kid when she was 14, and now she's 14, and this is happening to her. And I say happening to her because what was actually going on in this youth's life was mom said, absolutely under no circumstances will you seek reproductive care. That is not the thing that I want you to do, which is this thing called termination of pregnancy. Mom said, off the table. And I had this like big moment of like, okay, so I think this isn't right. Kiddo doesn't think this is right. Mom does. I know that if this kiddo goes and seeks services, there will be eventually a bill mailed to this house, and the jig is up. It puts you in a really scary situation. And then also at the time, I remember knowing a school-based health clinic where there was some options that could be provided to this youth. And then also remembering that practitioner really liked family involvement, which I think is good. We're going to talk about family involvement in a little bit. This poses a lot of turmoil. So again, I have to now have kind of 4 different conversations with folks. Hopefully, they all work the way they do. I honestly don't know why that story ended because unfortunately the youth left services. This is the really, really challenging thing that happened. I heard from the teachers that things went well, but there was this really hard thing that occurred where there was a conversation that happened between me, kiddo, and I believe that the parent probably just pulled her out of services. So they don't always go the way we want them to. We want to tailor them to their needs, though. So remember, we're going to have conversations differently with parents, reference. There's going to be this other thing we're going to talk about in a little bit. It could be a DHS or probation or school. Then also, we want to be in small, manageable bites. My full recommendation, really quick before we keep talking about this, is expect EPE cycles or ask off or ask cycles to just be repeatable events. So you might provide a small thing like, did you know that when you're 14 years old, you can consent to a lot of healthcare decisions without parental permission? They'd be like, I had no idea. And then they might say, like what? Then I kind of start this whole cycle over again. Now, the other kind of thing that we're gonna be doing, you're gonna see on this side, these are actually specific MI skills that are used in each of these steps. So when we say elicit, we're going to be using an open-ended question or a reflection. So again, reminding you of that time that I told a youth that they could smoke all the weed they want and mom will leave them alone. What I did in that moment was a reflection. It elicited a response. I should have responded when I heard them say like, yeah, that's exactly, and I'd be like, but unfortunately, there's a reality here that you don't get. If I had added that, maybe things would have gone a little differently. The next thing you'll be doing is this thing called affirmations. There's a misconception that affirmations mean praise. Praise is really cool. Some people really, really need it. I had a really big cheerleader in my life growing up. Not everybody has that. Sometimes we need to temporarily be that cheerleader, but this isn't what we're talking about. What we're talking about is affirming people's strengths, values, goals. So for example, if I provide this thing about, keep using, even though it's not a rights situation, I'm gonna keep providing the example. If I provide that reflection of you just love to smoke weed all the time, mom will leave you alone, what I should also be affirming is, but you also really care about your mom and you don't want home to be a war zone. If you add that little affirmation, they'll be like, yeah, I don't want to go home and every day just be really, really nuts for me, you know? Then this last thing, we're going to ask them for what they understand. We're going to allow that information time to soak in. Then we're going to ask about next steps. Sometimes that next step is, do you need any more information? Do you feel like you've heard everything? What other questions do you have? What are we going to do now that we've had this conversation? So we're going to go through a lot of these cycles. So no, we're going to come back to this framework, but I wanted to share with you early so I can kind of keep going back to it as I share this other information. So let's talk about consent. Informed consent is something that I think should be really, really, really important to everybody in this room. If you've ever had a doctor who just kind of comes in and like does your healthcare to you rather than does their healthcare with you, you might know what I'm talking about. I think I've had a couple dentists where that's a big situation. I've had a couple dentists who I like to ask questions when like their fingers are in my mouth and I can't answer. It kind of feels that way. Instead, what we want to be able to do is have consent being an actual process and a fluid process throughout services. So no, for minors age 14 or older, this is different than a lot of things. So they have a legal right to seek diagnosis and treatment without parental consent. Diagnosis and treatment, there's no confidentiality there. And the treatment provider shall involve their parents unless the following things occur. It is not clinically sound to do so it's contraindicated in some way. It's going to be a weird kind of situation because if I'm thinking MI, I don't know a reason I would do that. So you have to kind of cross a couple bridges here. The client has been emancipated, so they're their own guardian essentially, or there is some sexual abuse by the parent themselves. In those situations, we can say we don't have to involve the parents. There's one other little fine print here, which is you have reasonable, if you can reasonably believe something like unwarranted, some sort of abuse will occur as a result of that disclosure to the parent, then you can also not involve them. But we have to document that. We have to have proof. And then so we end up in that kind of cycle again of we're documenting a thing that eventually may be read by that same person. So it's a little gray there. Is there anything else about kind of age of consent for these services that people are kind of curious about before I move on to the confidentiality piece around this? Because the consent is one thing, and that's only to enter services. Discharge is a really kind of funny other conversation too. Go ahead.
As this is different than like reproductive care minors, correct? Because I don't think that there is an age. What do you think, Mitch?
I actually might deflect to maybe a sex ed expert in the room if you know, but to my knowledge, it is also 14 for reproductive rights in the state of Oregon.
I think it's because it's a state thing. Yeah.
Beautiful.
It's super vague, yeah. But like if a kid were to come to a doctor and be like, hey, I need to like, you know, talk to you about birth control, get condoms, things like that, that like they won't stop you just because you're 13. Yeah.
Sorry. Yeah. It's built through the REA, the Reproductive Health Equity Act. So that's how it's provided as a covered service without necessarily having to go through the pitfalls.
And so I do bring that up. Oh, yeah. I do bring that up because sometimes I work with teams, and I don't know if this is allowed or not, but sometimes we use that as a loophole to help us with other conversations that we have, and no one needs to know about that.
Question about this. It talks about parents. Oftentimes guardians are grandparents and or DHS. How does this equate to guardians who are not parents and at DHS?
That's a fun question because when I was preparing to make this slide, I was astounded by how the language actually specifically says parent and not guardian. That was actually ripped specifically from the text. The kind of interesting thing is if you look at the other relating OARs, it says parent or guardian. So I would say replace that with the thing. And this is where it gets really challenging. This is why I said most of the time when we get to that magic number of 18, it gets different. I've worked with youth who are in OAA custody and then therefore are still technically minors till 25 in a lot of situations. So this still would divert to that thing, which is a little messy and murky too. But also, that's really cool information about REA. I like that. There was
Yeah, it's pretty fun. Are you going to talk about medication and how that might be a little bit different?
I'm not, only because my background isn't in prescribing. I didn't feel safe doing it. Maybe we have knowledge though.
Does this apply for like unaccompanied minors?
Ooh.
Because we do have several cases of teens coming through our SBHCs who are essentially unaccompanied, no guardian contact, no idea where they are. They're living with friends. They're living with, usually it's not even living with family.
This is this is the fun thing about that little contraindicated thing. Sometimes contraindicated is there's just no possibility. I've worked with that secure residential facility I worked with. One time I'm aware of, we worked with an emancipated minor who was houseless, which was a very fascinating thing to somebody to self-admit themselves to a secure facility like that. And the really kind of challenging thing is all the services were built around families. So we had to really loosely define family too. So this is where I would actually move things out of the regulatory, but also think about the practice point. And so we'll talk a little bit about that, or talk about that in a little bit, where I think there is an opportunity for us to not view this as a have to, but a get to. And then how do we get to? So I'll mention it in a little bit about the how. The other hard part about the unaccompanied minor kind of group for services is it depends on, are they unaccompanied and involved in the federal system for unaccompanied minors, or are they by themselves truly? And then that's where you kind of get into there isn't somebody necessarily to contact. So, but then if they're in the kind of federal system, that's a more challenging conversation. Okay, so when is the disclosure required? And this is where this gets a little kind of other odd. So they might have just told us we could. Then we get to. In a fun way, though, because remember, our teenagers have a different sense of justice and they want to have autonomy over themselves. I actually push back sometimes when clients give us full bore consent. Does anybody know why? Because actually, when I say clients, this isn't of any age group. I actually kind of push back a little bit when they say, yep, I sign off on everything. Why might I push back if clients say, yep, this person can know everything about my services? And they don't say it that way usually. Usually it's an initial down the lines of our consent forms.
Maybe because like they don't really believe you that like when you say like, is this okay? And they're probably just like assuming like, yeah, this is probably gonna end up being with my mom anyway. Like my mom's gonna find out anyway. So I just have to say yes.
Yeah, so one of them is they might just say, I don't believe you. And this happens with adults too. I worked with the reentry population, adult coming out of correction situations. And they would say, yeah, they just get to know everything. And I'd be like, hold on just 1 second. Legally, your PO is required to know X, Y, and Z. You can tell them whatever you want, but here's kind of what, and there's a reason for that is one, to demonstrate, I do have your interest at heart. The other one is to double check, goes back to this wonderful EPE. It's kind of a physical version of this EPE. I want to double check they understood the things they're initialing on. I have unfortunately probably killed a couple trees by shredding ROIs because we've had to redo them because somebody then understood their rights and responsibilities. So no, that can happen. I'm sorry to the trees. So what can happen a lot of times is you'll have a frustrated teenager come into the office because most of the time, and this is the really kind of odd part about my perspective from a substance use clinician kind of versus a lot of my other counterparts in other healthcare professions, whether it's mental health or otherwise. Typically, we seek care because we want the feelings, the uncomfort, the pain, or the suffering we're going through to stop. That's why a lot of people seek healthcare. I go to the dentist because my tooth hurts or all of those sorts of things. SUD is a very interesting thing because sometimes folks will come on their own volition and say, I want help, please help me, whatever it'll take, I will do. It's a very, very small percentage of the folks that come in our door. Then you have some other folks who said, my life's starting to fall apart, I'm a little nervous, what do I do? Then we'll have some other parts of the population that'll say like, so-and-so in my life is saying that they might change their interactions with me if I don't do these things. And then last, there's, I have to do this or else. When those I have to do this or else folks come in the room, they're coming in thinking they don't have autonomy and they're frustrated. And as a result of frustration, I don't know if there's anybody in the room that does this. I always like to joke around. If you want to test your relationships, hang up pictures in your house and you get to figure out who has the needs to know if all the pictures have to be in a line or straight or crooked. You really get to figure out communication skills. Our youth kind of come in with that same level of frustration of, I just want to get this done, leave me alone. It's going to be 2 hours appointment. I just want to leave. And so, yes, I'll sign on everything you say because that means I get to leave sooner. We can slow things down a little bit and set a tone and be a little bit more engaging. So I want to tell you about this counselor I worked with named Alan. It was my first day working at that really cool youth service job that I talked about that I got that random email from. And I'll never forget this interaction that I saw Alan do because the kid kind of came in the room. I think this will be in camera. But the kid came in the room and just did the thing that we've seen a lot of teenagers do, which is... And I loved it because what Alan did is he pulled his chair into the room, sat at his desk, and he leaned back just like the kid, leaned forward, grabbed a stick of gum out of his desk, put it in his mouth, leaned back, looked at the kid, and he's like, hey, wait, do you want a piece of gum? And the kid excitedly was like, yeah. And then I watched his, he leaned forward, and he said, so, why are you here, man? And he's, sitting there chewing his gum. He's like, Mom told me. He's like, oh, that sucks. What kind of music do you like? And he just kind of avoided the reason that the kid was in the room for the longest time. And then he said, hey, I know you don't want to be here today, but, is there anything I could tell you right now that would make this just, fly by for you? And I remember him saying, hey, what does my mom have to know? And he went through the list. And he said, does she have to know about, and I really can't remember what the thing was. And I remember Alan just saying, oh, no, that's not my dog. I'm not going to worry about it. And it was a really human conversation that was had about a legal topic. And I never had seen it before, and I was so happy to have witnessed it. And that's really what we want to be doing. We want to make these conversations engaging because we want to make our youth care about their rights. Because I think there's a really interesting thing happening in the world right now where a lot of people feel like they don't have voice. So let's give people that voice if we can. Now, sometimes though, we have to take away that voice. And so this is why I have this kind of back and forth. Sometimes somebody may deteriorate to a point where we have no choice. And those happen for different reasons besides just the big one that I put on the board, which is suicidal ideation that is actually like intent and impending. Call it an immediate risk. The other reason that this can occur, I would mention that youth program that I worked in that was locked down, was for victims of domestic sex trafficking. There'd be a lot of conversations where I would hear the phrase, my boyfriend. And I would have to stop the conversation and say, just a reminder, before you say anything else, if I learn about the ages of this person, there may be actions I need to take. Do you understand? And they said, yep, totally, thank you, Mitch. And then they would continue their story. And then oftentimes I'd be like, hey, so just so you know, like you did tell me something that I do have to go make that phone call. Like no judgment from me, but it is a thing I'm required to do. And they'd be like, yeah, I know. I just wanted to share that with you. We create trust, we create openness, we create differences. This is the really big thing why this is so key too. In that same conversation, we know that people who talk about suicide, it doesn't increase the likelihood of it, but we don't want to shut down those doors because we know that people who don't feel heard don't talk about it. But it is a thing that we may have to take away somebody's rights to kind of resolve. So let's have those conversations early and often. When we're making the safety plan, most organizations or kind of healthcare providers that I know, if you answer yes to a couple questions, it's a requirement you do a safety plan for self-harm or suicidal ideation or even homicidal ideation. Do folks have those in their workplaces? Okay. So when those things happen, it's really important to make that safety plan be personable. This is still a conversation about consent and rights because what we're actually going to be saying is if this plan doesn't work, here's this thing that might occur. So how do we know this plan doesn't work? And rather than somebody say, I'm going to watch TV, I'm going to watch YouTube, I'm going to scroll through TikTok. Were people up late scrolling through TikTok last night or just me? You got to keep up with the youth, okay? No. So when those things happen, though, we have to be able to reflect back to them very quickly. And one of the things that was always really fascinating to me is we would be in situations where when I became a supervisor, I would have counselors who say, I have to go tell somebody they need to go to residential, or I have to go tell somebody they need to go to the hospital. And I would say, you know, I can tell you're really stressed about it, but why are you stressed about telling them rather than stressed about the experience they're about to have? And that's really what we need to be worrying about is about 3 steps from now. Let's really humanize the impact this is going to have on somebody's life and then lead with that conversation. Say, hey, when you first started with me, I promised I would always be transparent, open, anonymous, and respect your autonomy. I'm worried though. And you know what? There's some cool stuff that happens in human services where we actually are serving humans and humans understand that. They'll feel I'm not doing this to you, we're doing this together and I'm going to be with you. You're not required to disclose information if, again, you believe that that person that you'd be disclosing to has abused. So it's believed, you don't have to have proof. But again, remember, there's a documentation thing here. Sometimes the documentation, depending on your organizational requirements, doesn't necessarily have to be chart documentation. It may be in a supervision note. It may be in all these things because you consult. If you've been to LifeWorks, Mark Lewinson might have given you that spiel, and it's really good. Consult. If you've determined that it's not in the best interest to disclose this information, I really like this bullet point is here. It's provided to us by legal frameworks. It's also provided to us in a lot of funny spaces. For those of you that ever use the ASAM criteria, there's this really fun reason that you could disagree with the level of a care assessment as described in the ASAM criteria, which is my provider belief says that the ASAM criteria is wrong. They actually give you permission to do that. I've never used it. I'd be afraid to do it, but you could. And in this situation, you get that same ability. I believe as a provider that if I were to do the following, this would get worse. I worked with a family who were Somali refugees, And there was this really interesting thing where every single appointment that my client had, entire family would show up. I'm not talking about immediate family. I'm talking about cousins. I'm talking about aunts. We'd have like 13 people in the room. It was really beautiful that they supported them so well. And I remember every single appointment, mom would come in the room and say, "What did my son tell you?" And it was a really hard system to navigate because you had 13 people in the lobby who all really, really cared. And I had to say, "I'm sorry, but I don't want to disclose that." And the hard thing is, I wouldn't be the one who bore the brunt of that. The kiddo would. So we actually had to start to kind of have these conversations as a family unit, which I'd never experienced. We had to say things like, "Hey, just so you know, your teenager has an hour with me a week, has a bunch of hours outside of here, and those hours are yours as the parent. I would really love if there's a way we could just like figure out how this could be a safe place, and and there are other things that I could tell you or I couldn't tell you." And believe it or not, mom was like, "Yeah, I totally get that. You wouldn't." And there was like a framework. I wish I could remember where they came from, where there was an elder who they're like, "Yeah, you never get to know what they talk about." Like, okay, so look, can we pretend this is the same thing? Like, absolutely. They respected it. It was cool. But that took bartering. That took 4 weeks of conversations. That wasn't an easy thing. And so what this also means is sometimes our work for informed consent is also from an advocacy role. And that doesn't stop with just the parents. It could be for funders, because I'm describing things that are very idealistic, because sometimes you have 74 clients and 8 hours in your day and more clients coming in that you want to help. And we're saying, and I'm kind of encouraging you, hey, an informed consent conversation might take 3 weeks of somebody that you normally meet with for 12, which might require some bartering with CareOregon. I wonder who they are. No, it might also require some bartering though with your supervisors, with your organizational policies, those sorts of things to make it happen. However, this is a really cool little bit here. The person providing treatment shall have the parents involved. We go back to this thing. And I use this little chess thing because I actually think that this is where the strategy of what we're doing calls in. This is where it actually gets more interesting to me. Because most of the time we're not going to have clear indications that what I'm doing needs to not involve the parents. And in fact, most evidence-based practices that involve adolescents or younger kiddos really say family involvement is key. So then we have to figure out, what does family involvement have to look at the most intense level and the least intensive but safest level. That's what we can do as a clinician. That's what we're really empowered to do. So the other kind of fun part I just want to say here really quick is parents can refuse. And I've had situations where I've explained kind of the limits of confidentiality. I've explained the messiness. Because I'll say things like, "Hey, just so you know, if your teenager had come in there on their own volition, they were 15 and wanted to get support, they would be entitled to privacy up until this point." And then usually mom or dad, some sort of parental figure, even DHS at times, even probation says, "Hey, is it okay if we just do that then?" That doesn't happen often, but sometimes they would say, "Could we just try that out?" And I would say, "Sure. Under what circumstance would you like to abandon that plan?" And they'd say, "What do you mean?" And I would say, "If, let's say, they don't show up for 2 weeks in a row, would you like to be informed?" And they'd say, "Yeah, I think I would want to know, because then that wouldn't be the plan." I said, "Cool." So then I turned to the youth and I'd say, "Hey, so if you don't show up 2 weeks in a row, your mom would love to know about your services, what's been happening. But if you show up every single time, they say this is Switzerland." And then the teenager says, "What the heck, why are you saying it's Switzerland?" And I have to explain the kind of complex nature of international politics. So that's a joke. Anyways, so the other thing that can happen is this person turns 18. Or they turn 14. I've heard this really interesting circumstance where working with a 12-year-old, then they become 13, and then their 14th birthday happens, and everything's different technically. We need to be looking ahead as providers, and this is why I kind of keep saying, like, let's braid our confidentiality and consent into our care conversations too. Because the fun part is we know this is happening. We have calendars. We have like 90 different pages that this youth's parents signed, put their birthday on it. We have a lot of information that this date's coming. So let's have those conversations with the parents too. Because what really, really is unfortunate is when you have an 18-year-old who has a mental health condition, a substance use condition, has some sort of medical condition, and they decide, I'm my own legal guardian now. I can sign on my own dotted line. I don't even want to come anymore. If we have these conversations earlier, they might actually stay in services to get the help that was sought out for them originally. Sometimes. Sometimes that doesn't happen, but we want to make sure it's happening through intention, not just because I decided to. Because the really, really scary thing that always happened to me with youth is you turn 18 and all the supports and services that are available to you as a 17-year-old through a 12 to 17 kind of just vanish suddenly. Transitional age is like a very freaky time, both if you're involved in the system and not. I haven't decided which is harder, to be honest. And so we want to plan ahead and to say, hey, in 3 months, everything's going to be different. What kind of supports do you need? The other thing we're going to say is, and what will be your decisions surrounding your health care? Because what will happen, especially when you go to that 13 to 14-year-old range, it isn't suddenly that all those ROIs are invalid or any of those things. That actually requires paperwork and process, because those technically, you can still consent your youth to services as a 15-year-old, so there's no reason that those releases all turn off. So you might have a youth who suddenly gets the rights of a 14-year-old, but all of their consents are already signed as a 12-year-old. So are there mechanisms in your organization that automatically cause ROIs to expire in a year? Do they only expire when services end? Does that mean you need to terminate a care episode and then restart a care episode? These are all things you have to know in order to have these conversations clearly and accurately. So here are the factors that I like to think about when we have those conversations, which is, who's the payer? This is this really cool thing that I started to call RHEA, which I knew about RHEA, but I didn't know this was a cool little area of way we can get help. Before Medicaid expansion, in Multnomah County at least, we had this really, really cool thing called the Sun Grant. Are there any people that were around that long ago in the field? Okay. Sun Grant was really, really cool because if you didn't have insurance, you just kind of got your services. It was really neat as an SUD provider. We got to do things like outreach. We got to do things like recreational activities. There was just this really great general fund to help youth, and it was for undocumented youth, for just anybody who didn't have insurance, people who needed gap coverage. And then Medicaid expansion happened, and we had Healthy Kids, I think, is like a middle point in that. The downside that nobody thought of was suddenly there is a payer. And I never thought I would say that suddenly having our healthcare paid for caused problems, but it actually caused some really unfortunate circumstances, which is suddenly we had to follow OARs in a different way, which I'm not saying that we don't follow the regulations, but with the Sun Grant, I got assessment +2 in order to complete my diagnosis and treatment planning. I only got assessment +1 at most for a lot of the kiddos that I was working with after that point. So I had to speed up these conversations. The other thing that started to happen, though, is who signs their kiddo up for OHP? Mom and dad, usually. So stuff started to get sent home in the mail in different ways. I had a lot of, 5? Oh my gosh, I have to hurry. I had a lot of kiddos who were in that boat that suddenly their parents found out they were in services. That was on me. I just didn't know. I wish I had known, but I didn't know. Then we also have to know the referent. Does the PO need to know all this information? How do they know all this information? And what does the guardian need to know? What I want to be able to do, because I think it's good to practice things, I want to give you a scenario to practice at your table with your folks. If there's 3 of you at a table, I would encourage having an observer to give feedback. If there's 2 of you, then you pick who wants to be the client or the person. But one of you is a 14-year-old who's brought to services by their parent for concerns that their child does not share these, and their child does not share the concerns. Whatever makes sense in your kind of workplace. And they just ask you, what if I just don't show up? I want you to respond to that, talking about their rights in a way that is actually true, because we can't just say, yeah, you can just do that whenever you want. Take like 3 minutes. I just want to know how that went, and we'll debrief and then hurry, because apparently I was a little bit more long-winded than I'd practiced being. All right, I'm so sorry that I have to strap you for time. Question, how did that feel? Did it feel wonky? Did it feel bad? Was this new? What was that like?
Give me a second. Thanks. Thank you. Exactly like we're talking about, like there's the parent having consent to put or ask their kid, or I guess mandate their kid to go to services. And there's also the consent that the kid has at 14 to services. So I think that's maybe where it falls on the clinician. And so I would just let them know, well, you have the right to consent to services. If you don't show up, I'm not going to tell your your parent. But if they ask me, then I am required to tell your parent that you're not coming. And let me tell you about your rights to privacy if you do decide to engage.
Ooh, I love that. Let me tell you about if and when you decide to come, how we could make this work. Like, I love that too, because you're saying there is a reality to this. There are choices you might have. And we use that word consequence in a negative light, but there's actions and there are consequences to all of our actions, positive or negative. And I love that you're saying, like, this is the opportunity for us to kind of walk through that. The other kind of like interesting thing is I think a lot of these laws are written in the kind of affirmative, not in the whatever the opposite of that is. They're written to tell us what we need to do, not necessarily what we don't have to do. And so understand that is the laws aren't going to be written to say, here's the ways to kind of weave in and out of the system. If so, our system navigation would be much easier. They're really written to say, here's what you must do. And if it's outside of that, then we get to actually have to think, and we have to look at organizational policy. And a lot of times, if you look at organizational policies, they'll have some answers for that because, you know, orgs don't want to get sued or do harm. So we want to make sure those are usually kind of fix that. Something I want to share really quick is here are some just kind of recommendations that I have in short. Is our consent conversations happen all the time. They happen at admission with the client. They happen at admission with the parent, guardian, or referent. I would have conversations with POs, blankly saying, what are the situations where I absolutely need to talk to you? Not because I don't want to work with them, but because that's the thing I want to be able to tell the client. Because what will happen is you end up with really, really cool situations that are caused by that one conversation. I had a youth one day who came in. He'd been on probation on and off. He was in OAA custody for about 6 years. He came in crying, sweat dripping down his face, and he said, Mitch, I'm freaked out. My probation officer has to know I drank. And I said, wow, this is the first time you've ever come to a provider and said, I had an oopsie, help me out of this. And I said, let's call Dave. I don't know why I still remember that PO's name. And I called Dave, and Dave said, oh my gosh, this is the first time he's ever come to us instead of us catching him. And he said, cool, just let him know I'm happy for him. That happened because we had a confidentiality conversation at the very beginning. I can't say enough positive about the youth drug court kind of probation wing that Washington County has. They did a lot of work to get there. And then we want to make sure we're planning ahead for those impending confidentiality changes, but also just really think about how intentional family involvement versus that thing that we have to do can impact care. There are a lot of opportunities for us to involve family that the youth will feel empowered by doing too. One of the things that we would often do way back when we would, at least in the first program that I worked with for youth, is we required at least trying out a community self-help group. We didn't care which one, we just wanted to do to try it. And what we would say is, at least once we want your family to come to a session. That session could be the last one, it could be the first one, it could be whenever you decide, but we do need them to come in here. And you know what would happen is they would come multiple times. Then they would say, can I bring my friend? And they would kind of extend out those invites. And eventually you have a lot warmer thing because they understand their rights. They're not afraid about what's going to come out of your mouth when they step in the office. And that's really what they're afraid of. So remember, if they can feel safe and psychologically safe with you, they're going to tell you a lot more. They're going to be more honest, transparent. And if there's something that we know about ACT, the acceptance and commitment therapy, is that when our clients are more transparent with us, they actually have better outcomes and feel less shame about their symptoms. So we can do that actually through confidentiality rather than it being an I have to, it's an I get to. I think that's all I have for you.